Let me go ahead and bring up some of these questions, and we'll get right to it. We'll see how many of these we can get through here today. So to begin with, this one, initially they were asking which beta blocker do you use for hypertension primarily? And then as sort of a follow-up to that, barring comorbidities where beta blockers are indicated, confirming is it the fourth line therapy behind thiazidides, ACE inhibitors, and calcium channel blockers? So a little long-winded, but hopefully that makes sense.
So in terms of the beta blockers, if you want to follow the guidelines, the American Heart Association guidelines would tell you that beta blockers, you only use them, at least in people with resistant hypertension, when you have used an MR blocker, thiazides, ARBs, ACE inhibitors, and calcium channel blockers. Kind of the step number 7, okay? But if you have a compelling indication, if they are history of heart failure or the history of heart disease, definitely by all means do it. Which beta blocker we use? So it really depends on, for example, if you have diabetes, we favor CareOregon. It's based on only one trial, the Gemini trial. Compare Metoprolol and CareOregon. And CareOregon did a little bit better in terms of blood pressure management and did not increase your insulin resistance. So we definitely like CareOregon better than Metoprolol in that setting. Also, in our dialysis patients, for example, CareOregon is not dialyzable. Metoprolol, some of that is off every time we put them on the machine. For people with resistant hypertension, and then you have gone through all these things that I mentioned, so we use vasodilating beta blockers. It's only like 3 or 4 of them. One is CareOregon, one is labetalol, the other one is nebivolol that is not in your pharmacy, by the way. And so those are the 3 that we use the most. And we usually, like I said, tend to use labetalol, but labetalol would be a good option because it's also a vasodilator agent, as well as CareOregon and nebivolol. I don't have a lot of practice with nebivolol at all, but those would be our options. And if you have heart failure, obviously you can choose between metoprolol and CareOregon. Both of them have shown improved outcomes in people with ejection fraction below 40%. So like I said, here in the United States, the guidelines tell you delay the beta blockers until you go through all these other things and your heart rate is above 70. But in Europe, apparently as of 6 months ago, they said, wait, if you can start somebody on a beta blocker from the get-go. I don't agree with that. I would ask a young patient to be a beta blocker, well, I can put them on a calcium channel blocker, and ACE inhibitor, maybe. So you have to really have a compelling patient for me to lower your heart rate and put you on a beta blocker.
But a lot of our patients here, or a lot of our elderly, our older patients, say at the VA, do have heart disease and do have a compelling indication to be on a beta blocker earlier than step 7. So I tend to use it earlier than the American Heart Association guidelines recommend.
Super helpful, super helpful. This next question is kind of a satellite question, really. It's a person's asking if you can elaborate a bit more on why Atenolol and Metoprolol should be avoided as antihypertensives.
Well, so with Atenolol, for example, Atenolol has been kind of the FDA, for example, will not allow you to do a study comparing your medication to Atenolol, because Atenolol has failed to really produce better outcomes than any of the other ones and any of the other antihypertensives. So some people would be as dramatic as say Atenolol should be placebo, and it's full of side effects. And for that matter, these other options like Metoprolol or the vasodilator agents are better because they have proven to be better in terms of providing better outcomes. So I don't remember when was the last time I prescribed Atenolol to anybody. If they're on it and they're doing okay, we don't change that. Atenolol in CKD patients, the half-life increases. In somebody on dialysis, for example, when I was a fellow many years ago, we used to give them like Monday, Wednesday, and Friday doses because they hang around for 48 hours. So we used to save a lot of money on Atenolol when they were on dialysis. So we don't want to do that. You have life changes and more side effects. But I think more insulin resistance in diabetics, we have better options, like I just mentioned, either Metoprolol or Propranolol. That's my take on those two. Just Atenolol has failed to have better outcomes than anybody else.
And in regards to the question about metoprolol, it's just not a very powerful antihypertensive. So if you really are looking for blood pressure lowering effects, you're just not going to get a lot of blood pressure lowering effect if you're starting with metoprolol. That's not to say that I never use metoprolol. So often what I'll do is if I feel that I'm over treating a patient, that is, say I have on carvedilol, but I want the cardioprotective effects of a beta blocker, I might go from, say, carvedilol 3.125 BID to a really low dose of metoprolol succinate daily. So you get maybe a tiny bit of antihypertensive effect, you get cardioprotective effect, but you're not getting as significant of a hypertensive effect as you would when you're using even a low dose of the vasodilating beta blocker.
Okay. Super great, super helpful. Should we manage patients with CKD similarly as CAD, given similarity in vessel size? And this is they clarifying with respect to ASCVD.
Well, we do manage them definitely similarly in terms of being aggressive with lipid control and blood pressure and so forth. But when we find lesions in the renal arteries, we usually don't go in there and open them up and put stents. That's mainly the main difference, because it has been shown to be that medications compared to revascularization in a lot of the patients have shown the same outcomes and the same mortality after 3 or 4 years. They've done 2 big trials looking at this. And that's the reason we're very exquisite about when do we put catheters in the renal arteries and when do we do angiograms and so forth. If you have a renal artery lesion that is 80% occluded in the right side, and your blood pressure is very difficult to control and you're on 3 or 4 meds, then we said, okay, let's do an angiogram, and then we put some contrast in there, and then we'll see how stenotic it is. But also the radiologist will check the pressure before and after the ablation to see if it is hemodynamically important. And if the delta pressure there is 10 points or higher in terms of pressure, they would say, okay, maybe if we put a stent in there, the blood pressure might improve and so forth. So we take all these extra precautions to make sure that if we intervene in somebody with a renal artery lesion, is going to make a difference. So we tend to be very picky about who gets it done, because you can have a dissection of that artery and you might lose that kidney. You can have rupture of plaques and have cholesterol emboli and so forth.
And and I would say in practice, if I say I've got I would say yes, sort of. The answer to that question, I would say if I have a diabetic, hypertensive CKD patient who doesn't have any history of cardiovascular disease, in my mind, they have cardiovascular disease. And so when I'm thinking about my drug choice, say they have resistant hypertension and we've got them on a calcium channel blocker, a thiazide, an ARB, and we're going to need to add a fourth, I would, because I know that they essentially have cardiovascular disease that's just really not either reared its head or been discovered yet because of their constellation of other comorbidities, I might choose a beta blocker before an alpha blocker, because we don't want an alpha blocker without a beta blocker anyway. But that might be a case in which I would say that a patient would benefit from cardioprotection, even though they don't have a documented history, because they likely have cardiovascular disease. I don't know if that's you.
Yeah.
I think that's a phrase I'm going to have to make sure that we incorporate everywhere. Their constellation of comorbidities. I think that is amazing. That needs to be incorporated everywhere. This next question is about labs. They're asking if you could just briefly review which labs to order and which meds to hold to test for hyperaldosteronism. I'm going to mispronounce this so poorly. Hyperaldosteronism in primary care.
Okay. Well, so you don't have to really hold anything, maybe besides spironolactone, amiloride, eplerenone, or aliskiren. So that's what the guidelines tell you. Those four medications, aliskiren is a renin inhibitor. So if you test your renin on that medication, it's going to be very suppressed. So it's not going to really help you. Spironolactone and eplerenone block the MR receptor blocker, and so it's going to increase your aldosterone. So it's going to fool you. And the other one is amiloride that is going to definitely affect your aldorenin. So besides those four meds, I usually don't stop anything else. And you stop, obviously, well, NSAIDs. You don't want to do this test when somebody's in motion. So stop the NSAIDs for 2 weeks and stop the other ones for 4 weeks, and do the aldosterone in the morning. I think those are the only things that you have to be cognizant of. I might tell you that if you check a renin on a beta blocker, you have to know that beta blockers decrease your renin. They don't affect your aldosterone. So if the renin is low and your aldosterone is high, you may have to think, okay, should we stop the beta blocker on this patient to see if truly the beta blocker that is inhibiting the renin. So that's another caveat that you have to be cognizant of. That's the most common cause for false positives on the aldosterone building ratio, beta blockers. But like I said, we usually don't stop ACEs, don't stop diuretics, don't stop calcium channel blockers, don't stop ARBs, and none of those except for those four meds that I just mentioned.
And as far as labs are concerned, when you are getting a renin and an aldo, they should be as early in the morning as possible, and make sure you're getting a potassium with it as well. Because if you do have a hypokalemic patient, so you come back, you get your renin aldo resulted and your potassium is 3, then you know that you can't really trust your levels because your aldosterone is going to be falling.
Got it. Okay. Thank you. Thank you. We did have a couple of questions as we get close to closing out here that are moving into like the behavioral health realm a little bit in terms of treatment. But from a behavioral health perspective, any other recommendations that you might have? One person had mentioned here the idea of, avoiding anything that we would try to stay away from, like guilt or shame-inducing comments, with the idea that that would worsen the condition or decrease the likelihood of like patient compliance. Any other thoughts you have in that sphere?
Yes, I definitely don't use guilt. I agree. That doesn't get you anywhere. I tend to use humor as my way to connect with people when I'm talking about behavioral health issues, and talk about my own struggles with fitting in exercise or foods that I can't stay away from, or try to find some common ground there. I also don't encourage big changes. So when I'm talking about sodium restriction, we talk about what a low sodium diet is, then I acknowledge that's really hard to do in our culture. And what I tell people to usually start with is start reading labels, and we look at how to read a label. And I say, just figure out about how much you're eating in a day. And if that's 8 or 5 or 10, then what you start at is eating less than that. So you don't have to you can't go from 10 grams of salt a day, I don't think I can use that, but 10 grams of salt a day to 2, because your taste buds are going to hate it. You're going to feel like you're eating cardboard, right? So you've got to make baby steps. And the important thing is that you're eating less. So I have a patient that I were working on eating less Jimmy Dean sausage biscuits in the morning to help his blood pressure. And that's, if he's gone from 4 to 2, like that's great, and that's a lot of sodium. That's a big decrease in sodium intake just by making that small change. And it hasn't been super difficult because I haven't asked him to give up his Jimmy Dean sausage biscuits. So I think if you're talking about small changes and talking about them as small changes being changes that can be more sustainable. So dropping 1 soda as opposed to going from a 6-pack to 0 is typically how I kind of approach those things.
And it probably feels more realistic, not only realistic, but it's just like you're not asking them to go into total denial of something that they have a positive association with. Is like just limitations, maybe easier to start approaching. So. And
I think also if you're, a lot of your patients, or at least I'm sure a lot of your patients and a lot of our patients, financially, it's difficult to eat a really sort of like recommended diet, right? So you can acknowledge that is true. And so, you can talk about eating frozen vegetables as opposed to canned vegetables and, trying to fit recommendations into a patient's life kind of wherever they're at. If you have a patient that's houseless, that's obviously going to be an entirely different, again, constellation of issues. Someone who's living in their car, that's going to be totally different than someone who's got a stable housing situation. So, I think, again, each patient's different, but I think you just meet them where they're at and you try to get them to make a tiny change, and tiny changes over time that can become big changes.
Makes sense. This makes sense. It's good advice. And I'm guessing this next question here might be our last one, I think, from the list here. But I'm guessing it's something that impacts at the VA a lot. Is this person comment that's very interesting that PTSD is a big factor and contributor on the list, and we're just wondering if there was more that you could share about that.
Yeah, I think acknowledging just the interplay between mental health and physical health, and recognizing that again, looking at the person as a whole person. So you might have patients that come in and say, oh, my blood pressure is just high because I'm stressed out. I'm stressed out because of X, Y, and Z. And then you have to talk about, well, is X, Y, and Z going to go away anytime soon? Because if X, Y, and Z is sort of here to stay, at least in the next several months, then we need to accommodate for that. And so I think PTSD is especially in our patient population, is something that our patients often deal with on a day-to-day basis, and truly can impact things like their blood pressure control. And so encouraging co-management with mental health, which is not always welcomed, can be helpful, or at least check in and see if someone might be more willing to address it or feel more open to talking about it if they haven't been in the past. You've got other.
No, I think right now in our institution, it's one of the they have plenty of providers here, and we can refer them without any problems, and they get a call or follow up very closely. I think that's a problem that we would have in the private setting, that we wouldn't be able to find somebody that can definitely help these patients, or at least listen to them and maybe start a therapy as fast as we could. So now here, it's just great that the VA provides all the support for these patients with deemed to have PTSD. And remember that there is data on air pollution and noise pollution that has been found to increase the prevalence of hypertension. So isolating this, living in a big city, completely different. Living in a city that is polluted will increase the blood pressure.
Okay, and it looks like you got one more question came in. I think this might be a little similar to the one we had earlier, but do you typically see further lowering of heart rate when switching metoprolol to carvedilol? And if so, how much?
No, I really don't see it. No. So, and we use available doses up to, now, the average is 25 twice a day, but in some patients we go even higher, 37.5 twice a day. Yeah.
They're over 80 kilos, use the heart failure dosing if I really need to, for hypertension.
But yeah, we don't see a big difference between the heart rate between the two.
And then this is we're all of a sudden it's like we have a theme emerging here. So I just want to make sure we squeeze these in if we can. Do vasodilating beta blockers like carvedilol and labetalol have a higher risk of orthostatic hypotension compared to other beta blockers?
You know, we don't have too many trials comparing one versus the other ones, right? So we know that in patients with resistant hypertension, the only thing that I can tell you is that they're well tolerated and they might give you an extra drop in the blood pressure than the usual other beta blockers because they vasodilated effect. So they have the beta agonist effect, beta blocker and beta 1, but they have these alpha blocking effect. And that's where we believe that in some of the trials, the blood pressure tends to be lower if you were to compare, let's say, carvedilol, labetalol with bisoprolol. That is not a functionality beta blocker. Do you gain more than 4 or 5 points? I don't think so. Because like I said before, there was one trial in diabetics and they used very good doses of metoprolol and carvedilol. And the blood pressure really was rather similar, maybe a little bit better with the carvedilol. But what won the battle in that trial was the insulin resistance. The metoprolol wasn't as good as the carvedilol. And the hypertensive episodes, they were really almost non-existent. But remember that in diabetics, you have to deal with this autonomic dysfunction in some of these patients. So some people might react in a different way. But in my experience, nope.
Okay, excellent. Thank you. You know, I think we have done the magical trick of getting through all of our audience questions that have been coming through the chat here today and somehow finishing on time. That's like when the planets are in crazy alignment. So that is an amazing thing. On behalf of our audience and everybody at CareOregon and our members as well, Dr. Rueda, Dr. Gustafson, just want to warmly thank you for all of your expertise and being so generous with your time. You have been phenomenal to work with putting this together, and I'm just really glad we got the opportunity to learn from you here today and to get this captured on video so that we can continue to share this in the months to come throughout the CCOs. I think it's going to be something that will hopefully make a huge difference for folks. So thanks for being so fantastic and so open to sharing your insights. And it's just been really appreciated. So thank you so much. And for our audience, just a couple things here real quickly, and we will set you loose, turn you loose on time, which is an amazing thing. I just want to mention the next session that we have in the pipeline here for MedZed is a little over a month away. We've already had open enrollment for this. It is April 25th is going to be something where we're focusing what we call care beyond custody, looking at the challenges of access to healthcare faced by people when they're released from jail, correctional facilities. Often people lack family support, stable housing. They struggle with mental health or substance abuse issues, and they lack the necessary skills to navigate all of the bureaucracy that comes with reclaiming their lives after being in jail, including reclaiming their health care, which has been going on during incarceration more than you might think. So we have some really great experts coming together to help us see how strengthening these medical correctional partnerships can allow our healthcare systems to do a better job of serving patients when they transfer and transition back to the community. So this is it's a topic we've never done before in MedZed. It promises to be really great, and I'm super excited about the presenters that we've been able to recruit to do this. So definitely enroll in this. I'll be sending this enrollment link out with your other information later on this morning. So keep an eye on your email for that. And that leads me to also mention CME credit. At the end, we just send out a quick link to a post-survey self-assessment that you can fill out real briefly. Be sure your email is correct on that. And then once we have all those in early next week, I'll be sending out copies of the certificates. And you have any questions, just be sure to let me know. So again, be sure to enroll in our upcoming sessions. We've got all kinds of good programming in place for you this year. A lot of it's new, which is really exciting. And again, warm thanks to our presenters, to both Dr. Gustafson and Dr. Rueda, and I feel compelled to express a thank you to the great Ian Youngstrom, who is CareOregon's video producer par excellence. This program would be nowhere without Ian's technical expertise and Chuck Yeager coolness under fire when things don't go as expected. So Ian, thank you as always for your help. And folks, we appreciate everything you do out there in the state of Oregon and beyond to care for so many of our members and help them find their way through the maze of clinical confusion and that constellation of comorbidities that were mentioned earlier. So thanks for all your hard work and everything you do. You make a tremendous difference in the lives of so many people. So we will see you next time. Thank you for joining us this morning and have a great rest of your day. Thank you.